Today, I would like to present a case. The case, let us first see about the background of the case, because this name is not very common, and actually it is reported everywhere that this is a rare case. So let us start with the background of the case. It is a liver proteinosis. It is also known as hyalinosis cutis 8 mucosa. The name is explanatory that there is a deposition of hyaline material in the dermis and in the skin and mucosa of many other organs. And also we will see on the course of our presentation that the hyaline material is deposited in areas other than these also. This is also known as Urbach wiethe disease, as per the names of the gentlemen who first reported and described its genetics. Two gentlemen actually, Urbach and wiethe. And though the from the case had been reported earlier, but the description of the case with genetic discussion, these were ushered by Urbach and wiethe. And as there is a deposition of hyaline material, that is lipoglycoprotein, it is known as lipoglycoproteinosis also. It is a basically metabolic disorder. It can be called a neurocutaneous disorder. It can be called a genodermatosis because it is genetically programmed dermatosis. And as it can cause some neurological manifestation also, it is amongst the list of diseases of neurocutaneous diseases. So let us first see whether our claim that this is a rare disease is genuine or not. Three very popular internet sites would see where it is written that liver proteinosis is a rare disease. The disease description of the disease starts with it is a rare disease. This is from Wikipedia also. It is written that fewer than 300 cases reported since its discovery, reported by Eric Urbach, etc. It is from the Wikipedia. And this is from the Medscape. It is written that more than 300 cases have been reported already, insurance figures are not available. And it is mainly seen that large periods of South Africa have been tracked back to single German male who settled in South Africa in 17th century. Actually, it is seen in an area of South Africa of a German descendants. So it is interesting. From that, it was assumed that this has a genetic background and gradually worked up. This is my textbook, Brooks textbook of dermatology. Here you see that it is written, there is a picture and it is written liver proteinosis. This is a very rare disease. What is also there? A textbook chapter of a disease which starts with this is a very rare autosomal recessive disease. This is quite obvious that seeing a case is a pleasure, is an opportunity. Would like to see albino tigers, white tigers because these are rare. So this is the idea of my presentation here, that I would like to present a rare case. It is nothing but a case presentation without much deliberation because there is a huge scope of deliberation, but that is of the specialist domain. But as this is a rare disease and it encompasses many specialties, would like to share this with you. Let us first see the clinical features. As it is a disease which is seen mostly in childhood. Actually, disease is suspected from very early infancy or in a neonatal period when the baby cries. The cry becomes hoarse. At times the cry becomes aphonic also. So it develops in early life, maybe within 1 month of life, there is hoarseness of infancy, the cry stops. When the baby puts more effort while crying, there are scarring from tibial injury or inflammation. Minor inflammation which the kid cannot recall. There are scarring, there are scattered atrophic pock-like scars. Pock-like means that smallpox-like slightly diminished scars. Actually, some few of the lesions they start as vesicle or papule and they gradually ultimately become scar. And so initially people may confuse it with erythropoietic porphyria, where there is a initial early childhood blistering with scar, but here there is no photosensitivity or solar aggravation of those. People may confuse it with congenital epidermolysis bullosa, but as there is a scar and scarring from tibial injury, but epidermolysis bullosa like presentation in the extremities are not seen here. And the lesions are very superficial. It is not very unsightly looking, at least in the childhood. Gradually, when in the adults, it becomes very unsightly. But in the unlike epidermolysis bullosa in the childhood, the scar is very superficial, and unlike epidermolysis bullosa, people there is no scope of confusing it with the tabular urticaria or prurigo simplex, etc., because presentation is not similar. Actually, person who have seen it will not miss it if he comes across this case even after 30, 35, 40 years. The diagnosis is so typical, presentation is so typical. The tongue is enlarged and firm, and so firm that the kid even cannot express, protrude his or her tongue beyond the lower lip. If he tries to, he cannot protrude the tongue beyond the lower lip. Associated with that, there is a short frenulum also. There are many infiltrates, like in the skin of face, there are many infiltrates. There are many infiltrates on lip, palate, tongue, epiglottis, pillars of tonsil, etc. also. What causes the cry to stop or shrill, or what causes the hoarseness of voice? That is the vocal cord nodules. In the vocal cords, there is a accumulation of the hyaline material, and that causes the hoarseness of the voice. There are nodules on the elbows, like xanthoma-like nodules on the elbows, and at times these may burst and form scars also. There is diffuse thickening of the pressure-bearing areas also, over the knee, over the elbows, over the scapular angle or border. These are also seen in some. This is an autosomal recessive disease, so presentation varies widely. In some people, something are there. In some people, some other thing are there. In 2/3 of the patients, there is that beaded papules along with the margin of eyelids. That is very pathognomonic. That beaded papules along margin of eyelids. It is very typical only for blepharosis. And there may be maldentition of the permanent teeth. Even there may be delayed eruption of teeth also. But unlike other diseases, like epidermal dysplasia, etc., the teeth gradually erupts. So there may be diffuse alopecia, there may be hypertrichosis also. The skin is dry due to the excess hyaline in it, and as the hyaline is deposited around the sweat glands, etc., sebaceous gland, there is hypohidrosis. that laryngeal hyaline deposition may cause respiratory obstruction, that is that may at times be troublesome, and it has otherwise benign condition, but respiratory obstruction may cause life-threatening picture also. So this is to be kept in mind. There may be dysphagia. Dysphagia may be due to the inability to open the mouth due to the deposits in the lips and angle of mouth. Dysphagia may be due to the deposit in the pharynx also. There are reports of GI bleed due to the hyaline deposited in the inner mucosa of the GI tract and bursting of that. Seizure is a presentation because we will see that there is hyaline deposition in the brain also, in the hippocampal region, in the temporal lobe, bilateral ring-like deposits will be there. And there may be attacks of rage, there may be headache, there may be learning deficiency. It is not that everything will be present, something will be present, something will be absent, and the range of expression varies hugely. This is the finding. First one is the radiology finding, X-ray finding that we can see. That in this area there is calcification. Calcification in this parietal lobe area, and in the CT scan there are bean-shaped calcification in the hippocampal region of the temporal lobes. And this is plain radio X-ray that there is calcification of the temporal lobe area. So what is the etiology? It is a chromosomal, it is a genetic disease. Problem is in the chromosome 1q21. That gene actually is responsible for the extracellular matrix protein 1. That chromosome and that extracellular matrix protein 1 encoding gene that gets mutated. And that mutation is of varied nature. The exon 6 may be altered, the exon 7 may be altered, and according to the alteration and range of alteration, the presentation varies. And the deposition of hyaline material is everywhere. It is hyaline material, no doubt, because it is PAS positive and it is dashed as resistance. But the exact nature of the hyaline is unknown. Like we can tell the nature of the amyloid in amyloidosis, deposition of amyloid material it is known, but the hyaline material also it varies. This is the histopathology. There is epidermal hypercortesis, that is the epidermis, that stratum corneum level is thickened. There is irregular acanthosis, that is the layer of epidermis, lower layers of the epidermis, stratum granulosum, stratum spinosum, these layers are thickened and it is irregularly thickened. And there is the dermis is also thickened, that is there is deposition of extracellular hyaline material, and these are more around the appendages concentrically. Reduplication of basal lamina is there, which gives an onion peel-like appearance. There is accumulation of type 4 and type 5 collagen, and type 1 and type 3 collagen are less. If we see from a larger picture, this is not the picture of our patient. These are basically on discussion. The stratum corneum is thickened, and in this area especially, there is the thickening of this stratum spinosum and stratum granulosum level, and there is duplication of the basal lamina, and the dermis is also thickened. There is the red hyaline deposits which are around the appendages of skin. In more advanced cases, there will be so much deposition that there will be alternate vertical bands of hyaline material side by side. So, if we try to establish the disease by some simple laboratory methods it is not possible, because no laboratory findings are consistently abnormal. And ESR may be raised, that may be due to the increased level of globulins. So polymerase chain amplification and direct nucleotide sequencing of the extracellular matrix 1 gene can confirm the diagnosis. This is the way we can establish our diagnosis, because without the gene sequencing we cannot establish our diagnosis. We can we can but we cannot confirm, and that in future there may be immunolabeling of affected tissue with polyclonal antibodies against the extracellular matrix 1 protein. If that comes, then that may be a faster, more efficient way of detecting those mutations. Now we are coming to our case, because till now we have, I think we could establish that this is a rare disease. Then it is an opportunity to see this rare case. The pathognomonic sign in the presentation is the pearl-like beads in the eyelid. There is no loss of cilia, but in advanced case there may be loss of cilia. And there are few new lesions which we can see. These haven't turned into the scars, but there were small vesicular eruptions which have burst. This seems very early childhood. Here also we can see the beads. We can see in that area we can see one scar also over the eyelid. This area, if we can try to see, there are very mild superficial scars. Here is one. This is the back of the guard. Many that poke-like scars are seen here. These all are poke-like scars. It is well distributed, and this pigmentation is very light pigmentation. But all these are a bit diminished from the surface. This can be appreciated. This can be appreciated. But these are also a bit depressed, like the scar of smallpox on face, or the scar after the attack of epidermolysis bullosa gets subsided. It is like that, or that for that matter in erythropoietic porphyria. This is the upper thigh and upper thigh lower buttock region of that kid. The scars we can see, there are many. This is the elbow. In elbow also there are the scars are seen. Till in the elbow there is no xanthoma-like nodules, but with age there may be eruption of xanthoma-like nodules on the elbow, on the knee, in the body areas which gets friction. This is the tongue of the girl. You see that this is her maximum protrusion of tongue. She is trying to protrude it maximally, but then she cannot cover the lower lip. And the tongue is quite thick, and there is a small scar on the angle of the lip, upper side. There is a maldentition also. Maybe it is due to the disease, maybe it is not very significant. And this is to compare baby can protrude quite long, and tongue is not that thick in a way. So discussion is no cure is known. There are reports of treating it with penicillamine, then dimethyl sulfoxide orally, potent topical corticosteroid, etidine, acetyltratin, etc. But as the number of cases are very few, there is no large number of studies, and while some paper have advised some treatment, there are other papers to contradict it. So, medication summary is no pharmacotherapeutic agents have been established as effective for the treatment. But as that apnea, hoarseness of voice, or at times that respiratory distress may be troublesome. So, in advanced cases, dissection of vocal cord papules have been useful in improving the vocal quality, and nowadays laser ablation of the vocal nodules are also may be tried also. And if the scar in the skin over the exposed areas become very unsightly, then dermabrasion may improve the cosmetic appearance. So, what are the complications of that? This is laryngeal involvement may lead to airway obstruction, and impaired speech is present since very early childhood, that hoarseness. That intracranial calcification may result in seizure. There may be grand mal or petit mal seizure, which can be treated quite effectively with anticonvulsants. There may be behavioral changes, rage attacks, dystonia, etc., headache, and the deposition of iron in small bowel is reported to cause GI. Prognosis, lipid prognosis has a very stable or slowly progressive course. Life expectancy is like a normal person if there is no fatal seizure attack or respiratory problem. The presence of this disease is compatible with the normal lifestyle. If there is no airway obstruction or fatal seizure activity, mortality rates in infants and adults are slightly increased because of the laryngeal obstruction. This is the key from Urbach. Actually, she had been treated for long for people thought it is a case of seborrheic blepharitis, and gradually while seeing other things we could know that this is a very rare case. But the girl sing songs, and till now hoarseness is not very prominent. But her mother says in the early infancy, when she tried to cry loud, the cry stopped abruptly. So that is a thing that maybe on extreme effort the larynx collapses and the cry stops. This comes to the end of my presentation. Thank you.
What are the tips you are